Hello, everyone. It is my great pleasure to welcome you to this PCR webinar. I am here with my very good and esteemed colleagues, Henrik Dreger from Berlin and Flavio Riboccini from Verona. So I think all three of us want to welcome you. The title of this one is How to Ensure Coronary Access After Transcatheter Aortic Valve Implantation. And just a brief overview, if we could forward to the next slide, please. Our learning objectives for this webinar are to, first of all, learn about the importance of ability for coronary access after TAVI. Then, of course, we want to discuss with you, hopefully, to understand how the design of transcatheter aortic valves, different valve types will influence coronary access. And finally, learn how to achieve patient-specific coronary access during TAVI. So we have 60 minutes and we want to make good use of time. So if I may, I want to introduce Henrik for the first talk. He will give you an overview on the concept of coronary accessibility by commercial alignment. And by that, I think, pave the way for a few cases that the three of us have prepared for you. Henrik.
Thank you very much, Leonard, for the introduction. And it's been my pleasure to be invited here to give a few introductory slides about the concept of coronary accessibility by commercial alignment. And I think as a TAVI operator, we've all had this same experience, I think, over the last years that doing a coronary angiogram in a patient after TAVR can be a little bit of a challenge sometimes. And of course, this is an important issue because according to our experience, of course, but also according to registry data, the prevalence of coronary artery disease in TAVR patients is about 50%. So it's a relevant issue that we should be able to do a coronary angiogram even after TAVI. And as you can see in this short image here or this angiography, it can be a challenge at times. And the question is it just our inability or what's the reason for that? And of course, it's not the operator's fault. It never is. But here we have the data to show and to prove that the struggle is real. And it's because that in many cases, the ostia of the coronary arteries are basically hidden behind design features of the prosthesis that we usually implant in our TAVI patients. And this is especially true for long frame stand self-expanding valves such as the Evolut platform. And as you can see here in summary, if you check for all the obstacles that these long stand frames may provide in self-expanding valves, up to 35% of the left coronaries are hidden behind some features which give us then real struggle to engage them selectively by guide catheters. And this is also true for about 26% of all ostia of the right coronary artery. This is less of a problem in balloon expanding valves, which of course have much shorter stent frames and therefore hide less of the coronary ostia. So the question, of course, is this just a little bit of a nuisance? Is it annoying or is it really relevant for clinical outcome for our patients? And there have been published two papers basically based on registries over the last 12 months. And one was from Germany by Dr. Kim from Bad Nauheim. And he analyzed patients who developed an acute coronary syndrome after TAVI and checked if there was any issue with the coronary access that impeded a successful PCI in these patients. And indeed, he divided the population of these registry patients in two groups, basically short frame, which was mainly Sapien platform, and the long frame cohort was basically an Evolut. And you can see here that, confirming the data from these CT studies that I initially showed, which already gave us a good indication why we could have a problem engaging the coronaries, that this is indeed a problem also in patients that do have an indication for an urgent coronary angiogram. And as you can see in this short diagram, in the long frame cohort, about 63% patients had an angiogram where at least one vessel was unselectively analyzed, and the guide was unselective in about a third of these patients. So it is kind of relevant, as you can see, more than just a nuisance. And in total, the failed PCA rate due to coronary access issues was about 2.5%. So again, there is some struggle, but in the end, 79%, if you want to talk about the glass half full, can at least be successfully treated by PCI, even though we have some struggle with selective guide engagement. And the other trial, or the other study that I mentioned, included patients that actually had a STEMI, so a more severe form of ACS after TAVI. And you see in these little diagrams here that the door balloon time was significantly longer in TAVI patients compared to non-TAVI patients with a STEMI. And the rate of PCI failure was significantly higher with 16.5%. And even though there was no comparison between a control group, the overall data regarding outcome with the endpoint death was really bad compared to what we usually see in a STEMI cohort. This, of course, can also be contributed maybe to the TAVI population being high risk itself, but it's not very encouraging. So it, I think, underscores why it's really important to have the issue of coronary accessibility in mind when we do choose valve platforms, and also how we choose to implant them. Because how we choose to implant them has a significant impact on the accessibility, as we all know. If we have commercial misalignment, as seen here on the left, of course, it's really hard to engage a coronary, but if we have commercial alignment, it's much easier. And this is, of course, what we have to aim for. And last but not least, we are talking about coronary access issues, but I think this is even more important if we see patients with a diseased or with a deteriorated valve, which might need a redo TAVI, such in this case that we recently saw in our clinic, an 87-year-old patient with a deterioration of the valve function of a core valve that was implanted in 2013. And yes, you can see the right coronary is not really good visualized by the coronary angiogram because of the unselective guide placement. And the reason for that has been, or was revealed by the planning CT for potential redo TAVI, and there was complete misalignment of the core valve. And of course, combined with the effaced sinuses and the high neoskirt with this supraannular valve, there's a really high risk for coronary obstruction after redo TAVI in these patients. So in summary, it's really important for the coronary access, but it might be even more important in our now younger and younger patients who undergo TAVI if we have to do a redo TAVI in 10 years' time in these patients.
Very good. Thank you so much, Henrik. This was an excellent overview on the, the issue of coronary misalignment, coronary alignment, and so I think it's one thing to realize the conceptual problem that there are. The other thing is how to, approach this, how to technically avoid misalignment. And I think Flavio has prepared an excellent case where he will demonstrate to us on how to tackle this by implant technique. Flavio, go ahead.
Thank you, Leonard. Thank you, Henrik. Good afternoon, everybody. We will start indeed with a case. This is a case performed in our center with the implantation of an evolute valve, which is one of those that have been assessed in the series of cases that have been shown by Henrik. Please run the video so we show how it starts with the orientation of the valve. You see the flash port of the evolute is recommended to be oriented toward 3 o'clock in your watch, so to the right of the second operator. Then in the most likely possibilities, this will orient the commissures of the valve in a favorable fashion, not to be just in front of the origin of the coronaries. You see that the valve implantation is recommended to start in the cusp overlap, which is a caudal RAO, and then to be checked in the LAO to make sure that there is a full contact of the valve in the annulus. Then at this point we're retrieving and the valve is in position. In this case, we decided to assess the severity of a lesion of the coronary artery of the left main after the valve implantation. So we like to prepare the guiding catheter in this way using the wire connector, so you can check with contrast. Where is the tip of your catheter? You monitor the pressure, you can flash, and you use the 0.35 angiographic wire to open and close the curve of the extra backup inside the core valve. The core valve, it's a supraannular valve, so there is tissue and there is a valve in the upper part of this metallic structure. So you see that you have to work to find the diamond among the struts of the valve to cross the valve. You always need to cross the valve. So this is why the core valve is the most, let's say, demanding model of transcatheter valve when you need to catheterize it. But you see, this is a non-selective injection that with a gentle push, the tip of the extra backup gets easily into the left main, because the orientation of the valve and the sutures is favorable. In this case, you see that we are able to measure FFR on the left main stenosis, and you see that it's a severe stenosis with an important reduction of the fractional flow reserve. This is just to show you from the radial, from the femoral, I mean, it's the same vascular approach we use to implant the valve, that you can put the two wires, you can do an IVUS assessment. You see, it's a severely calcified vessel. This is the distal left main and the ostial LAD. So you work like in a normal situation. The guiding catheter through the valve struts, it's very stable, even though it might not be perfectly selective. So after the assessment of your physiology and the IVUS, as you would do in a simple non-TAVI procedure, you can proceed with the inflation and the stenting. So the performance of the PCI is not the topic of this talk. So the film will stop in a few seconds, because we don't need to show you how to do the PCI. But this was the intention of this case, was showing how to align the commissures of the valve in rapport to the origin of the artery to get an easy access to the corners. So now I can show you what is the aspect of the relationship in between the native root of the aorta and the transcatheter valve. So please show the next part of my slides, and you will see these are examples of CT scans performed after valve implantation. We start with this very difficult and demanding case. You see, it's a patient with an aneurysm of the aortic arch. Next one, with an endoleak. So he received, first of all, a debranching and a second endovascular treatment for the exclusion of the endoleak. But this patient developed severe aortic stenosis. So at that time, after several surgical and hybrid interventions, we didn't want to open this chest and the aorta again. So we did perform a TAVI procedure. Next, please. You will see the unfavorable anatomy of this ascending aorta. And you can understand it easily when you see the navigation of the core valve in this extremely horizontal aortic root. You see that the valve will get in, and after deployment is totally horizontal. So the alignment of this valve is very demanding. Next one, please. But fortunately, this is a CT scan performed more than a year later, because the patient had also a dissection of the ascending aorta, and we wanted to make sure that the dissection was well opposed after the implantation of the valve. You see how the core valve is totally horizontal. It's in a good position. Next one. And this is the rotational analysis. Please click on the left image so you can have a clear idea on the difficult implantation. But you see that the alignment to the right coronary artery in the lower right part of the right picture and in the upper part of the right picture is good. Next one. So this is an example of a good alignment. Next, please. Despite the very demanding anatomy of this case. Next, you will see the post of the valve and the origin of the right and the left coronary arteries. Next. This is what we call a good commissural alignment. Next case is again an unfrequent and very demanding anatomy. You see, again, it's an horizontal aorta, and this is type 1 bicuspid valve. Next, you will see in this case that there is a lot of calcium. You see the raphe and the aortic stenosis. Next one, the origin of the coronaries are normal, as expected, a little bit low, and the implantation of the core valve 34 is a little bit high. So this puts a situation that might be demanding in the future for getting into the coronaries. Next one. But at the follow-up performing this patient, you see how the valve at the exit outflow of the LV, it's compressed. This is normal with self-expandable valves. But being a supraannular, next one, the leaflets of the valve are okay, and also in this case are well oriented. Please click on the image and you will see the origin of the right coronary on the right picture and the left main on the right picture, and you see that the orientation of the post are perfectly aligned to the origin of the two coronary arteries. Next one. This gives you, again, a detail. Next one. And here you have, again, a demonstration of a good alignment. This is what we call a good orientation of the post and the sutures compared to the origin of the artery. Next one. Thank you. So that's it. I think that the two demonstrations we have done with the first slides from Eric and my case are sufficient material to start a discussion. What do you think, Leonard?
Great cases, Flavio, and beautiful images with those post-implant CTs. Thank you very much. So if I may, can I first of all ask Henrik, because we want to discuss both talks here, if after you presented this, I was thinking, how about, it's not necessarily so that people treating patients for acute coronary syndromes in your everyday cath lab at any given time point in the night are at the same time TAVR implanters, thus may not be as familiar with the TAVR valve. So how do you think that discrepancy should be addressed? Do you think everyone who is on call for a cath lab emergency needs to be a TAVR implanter? Do you think there should be at least a certain training? How do you foresee the future? Because of course, for sure, this is going to be a much more pressing issue in the future. Huh?
Yeah, I think this is probably something that cannot be solved by just having TAVI operators on call. I'm being on call quite enough already, to be honest. So, but actually, if you think, we had an interesting question a couple of years ago to also join another registry where we had to look for SES patients after TAVR in our cohort, and we actually didn't find that much. And then I started thinking, and then I realized, yeah, of course, they're going back to their referring hospitals in Germany and the area I am in. Usually, of course, patients are being transported or referred to our center for the TAVI, but the coronary angiogram beforehand is being done in a smaller center, in a smaller hospital. And of course, once they develop a problem later on, be it an acute coronary syndrome or just a chronic coronary disease, they are being treated in their referring centers. So there's no chance that an experienced TAVI operator will be the one who's doing the coronary angiogram, and especially not during the night when they have an acute problem. So I think it's our responsibility as TAVI operators to think beyond the day that we are treating the patient in the hybrid room, but to make sure that other physicians who might have to do interventions in these patients have an easy job, because easy means time saving, and this might be life saving, as we've seen in the data from the STEMI cohort from the United States that was published in the JAC last year. So I think similarly, I mean, I might not be the one who does the redo TAVR in one of my patients, but I should be responsible for making the redo TAVR as easy as possible in a 75-year-old patient who has a maybe 50% chance to live until he's 87. And then, of course, there's a high chance for a deterioration of even a perfectly implanted valve.
Yeah, very good. So I'm curiously somehow reminded of our surgical training, where of course we take it as natural to implant surgical valves in an orientation that is close to physiology or to nature. So why should it be different, right, with transcatheter heart valves? Flavio, how do you do it in Verona? I mean, I'm sure it's similar that not all people on call in the cath lab are perfect TAVR or TAVR implanters. Do you train them in-house? How do you tackle this?
Yes, well, I try to underline two important issues. The first one is that this is a PCR webinar. So this is performed with the sponsorship of a company. I think it's Abbott, if I don't go wrong, but their support is unrestricted. So it's clear that we start showing a core valve, and we will show any kind of valve, because our interest is not on one valve type, it's on the technique. And I really hope that most of our colleagues attending are not TAVI implanters, because the real issue is for those who do not know the type of valve, who do not know the technique of orientation and recatheterization. For people like we are, TAVI implanters, it's much easier to engage these coronaries. I tell you, in Verona, it's already 6 or 7 years that we ask our colleagues engaged in the on-call service to get into the lab and to recath the coronaries after we implant a core valve or an Edwards or a Portico, because they will be on call. They are on call, and it might happen at any time that they will need to get into the coronaries. This we have been doing for years, and this is why we have such a, I'd say, good outcomes in trying to engage the coronaries. And this is something I really advise to other centers to train their colleagues being on call. For those who are not in TAVI centers, I think these kinds of webinars are very important, that as many others, and then the possibility of attending a TAVI center to get involved in this very important issue, because as Eric showed very well, when the patient coming with a STEMI and having a valve in between your catheter and the coronaries, things might be difficult. But the main issue I want to share is that difficult doesn't mean impossible. And the more you train, the easier it will be.
Perfect. Flavio, that's a perfect introduction. I mean, you mentioned different TAVR devices. You mentioned, we already got a hint of that from Henrik's initial presentation, that there might be a dependency on the type of valve. So, Flavio, why don't you go ahead and give the next talk? You were so kind to prepare a presentation of a comparative presentation of THV designs with regard to our today's topic. Flavio, the floor is yours.
Well, you have seen before the orientation of the core valve, but each valve has its own recommended technique. So please show the designs. This is very important, that all cardiologists should be confident with the different valve types. On the left, you see a self-expandable supraannular core valve, which is supposed to be the most demanding when you want to get into the coronaries. This is why you see that the valve is above the starting of the valve. There is quite a high skirt of tissue, and the commissures are a triangle, and if the orientation is not good, this triangle will end up to be in front of your corner. It doesn't mean that you will not get in, but you have to turn around, and this may be difficult. Fortunately, the struts of the valve are quite large, so you can get either anterior, posterior, superior, and in a certain way, you will manage to get, even if you are not selective, with a wire, with the balloon to make an anchoring, or with an extension catheter, and in most of the cases you will manage. But this can be difficult. In the lower part, you have the balloon expandable. This is intraannular, so the valve is at the level of the annulus, and most of the valve material is above the leaflets, and so most of the space that might be in front of the ostia of the corners is just some metal, but there is no tissue. Next one, please. This is the detail in terms of millimeters how the core valve is done. You should know that, because according to the first image you get with a non-selective ascending aortography, you will understand if the valve is very high, it will be more difficult. If it's low, it will be easier. If the origin of the coronaries are low, it will be more difficult. If they are higher, it will be easier. Next one, please. Here is an example. You see how easily the left main was catheterized and the stent was implanted, but you see that it is very in the center image, in the two superior images, you see the good commissure alignment, a very similar example to what I showed you before. Next one. Go ahead. This is the Sapien 3 and the Ultra, and you see how clearly you can understand that the origin of your coronaries with a good implantation will be free of this valve because it's much shorter and the tissue is limited to the inferior part of the valve model. Next one. And so this is the valve that can be more easily catheterized. Please go to the next image. This is the structure of the valve. You see how large the struts, the metallic struts are. Next one. And most of the time, the coronary ostia, as you can see in this picture, go ahead, click so you will see the sequence of the images. The coronary ostia are above the metallic part of the valve. Indeed, in the studies that Henrik showed, it was always possible to re-engage the coronaries with the Sapien model. Next one. And in the next one, we see the accurate neo. This is, again, and self-expandable with, as you can see, a much shorter quantity of tissue in the skirt. And because of the different system of valve deployment, you see the hooks for anchoring in the distal part, which are very short. There is a large opening of the struts in the upper part. So this is quite a very easy and straightforward valve to re-engage the coronaries. Next one. And this is a demonstration of all different types. Please click on it so you will see the difference on intra-annular and supra-annular. Of course, the supra-annular have more tissue getting close to the ostia of the coronaries and a little bit more demanding, while the portico and the Sapien are intra-annular. So the leaflets of the prosthetic valve are lower, and that means that the possibility of staying in front of the coronary ostia, it's less likely. And the portico, which has another important advantage, you can see how large are the spaces in between the metallic struts. So this makes the engagement of the coronaries through this large cell design self-expandable valve much easier, almost as easier as the Sapien 3. So this is what I wanted to share with you. Have this in mind. Everybody should know this kind of valve, even if you are not involved in the TAVI program, because tonight, you may be called to open one of the arteries of a patient having one of these type of valves.
Very good. Great overview, Flavio. Thank you very much. I think we have just a minute or two because we have a question from the chat. Amir Abbasam is asking, and I guess this question goes to to Henrik or Flavio. Do you think we have to use guideliners to access coronaries in some types of valves? Henrik, what do you think?
Well, it definitely can absolutely help. If you have problems engaging the coronary selectively, many cases you at least are able to put a wire in, and the guideliner system or any mother and child catheter might be able to then cross even a very narrow diamond, such as an Evolut, and give you a lot of backup to implant stents and fix something that needs to be fixed in a coronary, even in a challenging anatomy. So absolutely, it's a great tool.
Mm-hmm.
Yeah,
thank you.
I would just add that it's an idea to start with a guiding catheter, because if it's getting difficult to get with the diagnostic and then you have to proceed with an intervention, you will not be able to put either a balloon or an extension. So always start with a guiding catheter. It's the same size, 6 French, and you can have this additional opportunity of using extension, balloon, anchoring, or whatever. So don't waste time with a diagnostic catheter.
Okay. Good advice from the two of you. So let's be respectful of time. I think we'll go on. Flavio has nicely demonstrated the whole array of transcatheter heart valve types. And I think, Henrik, you've prepared a case that you want to show us, which probably is one case, but go for yourself. You prepared it, so you best describe it too.
Okay, yeah. So I mean, Flavio has done a great job showing a Korvalf case and also detailing all the different characteristics of the mainly used valve types that we see in Europe on an everyday basis. So in contrast to his case, I wanted to show a similar case where we also had to do a PCI right after TAVI, but used a different approach. And so let me just start with this case with a short summary. So it was an 80-year-old male. He was severely symptomatic due to severe low flow, low gradient aortic stenosis with an area of 0.9 square centimeters. He was, again, low flow, low gradient. So the mean pressure gradient was only 28 millimeters of mercury. And the reason for that was basically, sorry, that was too fast, that he had ischemic cardiomyopathy. And in his workup leading to the TAVI procedure, we saw distal left main stenosis of Medina class 110, so was an involvement of the ostium of the left anterior descending. And he also had a chronic occlusion of the right coronary artery. And more importantly, in this situation, or for the TAVI situation, he was also a patient with peripheral artery disease, and he was also a patient with diabetes. So we did, of course, the planning CT, which unfortunately revealed what we had already feared, that he was not a good candidate for transfemoral TAVI because he had severe calcification and very small minimal lumen diameters on both sides of his iliac arteries. So in the end, the hard team decision was to do TAVI, of course, due to his age and his high-risk status, and also perform a PCI of his left main. But due to the fact that his left main, or the left, was the last remaining vessel, we wanted to do it in impeller standby. And we considered that the femoral axis might be suitable actually for transfemoral TAVI if we use shockwave or something similar for pre-treatment of his calcified iliac stenosis. But we feared that an impeller might get stuck in the common iliac if we would need it. So we decided to go for a transaxillary axis and then first do the TAVI followed by the PCI of the left main to be, to relieve his basically heart of the additional stress of the aortic stenosis. So it would probably be more forgiving if we had some trouble if we run into any trouble doing the PCI of the left main. So what did we choose as the valve platform? We went for a 20 millimeter Navitor. And the reason for that was that it has excellent transaxillary deliverability, but also due to his ischemic cardiomyopathy, we were a little bit worried about low flow phases. So we usually prefer a valve with an intra-annular design, which is basically working immediately, such as the Navitor upon release. So this was a big plus for us in the planning, and this is why we went for the Navitor. And in addition, of course, due to the intra-annular design, the large cells, we thought that this would facilitate coronary access, even though we didn't actually attempt any form of coronary alignment. So this is the implantation, and as you can see, there was no rapid pacing required. It was a very slow and controlled release of the Navitor, just as expected. And after that, we, of course, did an angio check and saw no parvo leakage and the good position of the Navitor. And this was followed, and I keep it brief as well as Flavio did, because this is not a PCI session. So we selectively engaged the left coronary very easily with a 7 French extra backup catheter, and then just performed a provisional stenting Podkiss post sequence. And this was a very easy case. And the idea was, if he had had any trouble with the PCI and he would have deteriorated, we would have been able to simply implant an impeller over the wire that we left in place from the transaxillary axis. But we didn't need it, and we're able to finish the case without any mechanical support within a couple of minutes. And his discharge echo showed a very nice valve function with only maybe trace or none PVL at all, and a mean gradient of 5 millimeters of mercury.
Excellent, Henrik. That was a spectacular case, not only because of the access, but because of the whole approach. I think made a lot of sense. I have to say that when we use alternative access, and I would be curious to know both of your opinions. When we use alternative access such as transaxillary route, I do like a repositionable valve because it can be a little tricky to get the valve where you want it. So of course, the other option will always be a Sapien, but as we all know, it's a single shot device. And so how important is that for you when you choose alternative access, Flavio, a repositionable device? And how do you judge this Navitor platform, which is immediately competent, which does not give you hemodynamic compromise in a cardiomyopathic patient such as this one?
Well, two short comments. I mean, the possibility of retrieving and replacing the valve and the fact that you don't need rapid pacing, of course, makes things safer when you treat patients with such an ischemic burden, like having a tight left main stenosis. So these are two added values of this type of self-expandable repositionable valves. And the other short comments, very wise, very smart to perform the aortic stenosis treatment before and leave the coronaries for the second part of the procedure, because any kind of complications you might encounter treating the left main, which might be a dissection or a low flow, would be very badly tolerated by a patient with aortic stenosis. So get rid of the aortic stenosis before, and then work on the coronaries as in a normal patient without aortic stenosis. Of course, you have to convince yourself that you will gain access to the coronaries, because if your problem is thinking that, oh gosh, I put a valve, I cannot get in, then it's of course you will be worried. But this demonstration, as the previous I've shown with the core valve, make it very clear. And I think this is a very wise advice.
Yes, this is actually a perfect transition to another question from the chat. Antonio Chalapas, please excuse my pronunciation if it's not correct, is asking, great case, nice case. In general, do you prefer to treat first the aortic stenosis and then the severe left main coronary disease? So, Hendrik, what's your take on this? I'm sure there are both ways to go. How do you differentiate this?
I think it really depends on the patient itself. If you have a patient with good ejection fraction, a large right, and you have something to fix on the left, which might give you some ischemia during a valve deployment, of course, it might be better to start with the PCI. But as Flavio, I'm happy he agreed, also said, I think in this situation, if you run into a problem with the patient and with a single vessel or last remaining vessel PCI, especially in the main stem, if you have any problem, then of course these patients will deteriorate really fast because they are not fighting only the ischemia but also the aortic stenosis. So they have basically no capacity to deal with with a couple of minutes even of ischemia due to maybe a dissection. And of course, I mean, this was definitely a case for a protected PCI. It's a left main with an occluded right. And putting an impeller into in a patient with an aortic stenosis that hasn't been treated before can be done, of course. But of course, you're putting basically something into a very narrow aortic valve. So you must be sure that the impeller is at least giving you a benefit and not making things even worse. Because if you maybe decide to go for only a 2.5 impeller, and this is not that much of a support, and so I think in many cases, the main stems that we treated in patients with aortic stenosis, in almost all cases, did it after the TAVI.
Great comment, Hendrik. Thank you very much. I think we need to move on. You brought another case using a SAM valve platform, but in a different setting, not only access-wise, but I think this was a case where you want to stress the importance of commercial alignment. So why don't you take it from here, Hendrik?
Yeah, thanks. So let me see if my clicker works again. Yeah, it seems so. So, I mean, I just mentioned that we not really did it in all cases, the commercial alignment over the last years, but I think we've learned a lot with the change of the guidelines to address our patients differently. And this is what I mentioned before, that of course we now have the responsibility to make sure that these patients might undergo a safe redo TAVI in 10 years because they're now 70, 78 or something. And of course this changed our approach. And so we now try to attempt commercial alignment in almost all patients if it's somewhat indicated, or if we believe that that there's a good reason for it, like a redo TAVI in the future situation or free stenosis. So in this case, I mean, she's an 80-year-old female. This valve will probably last for the rest of her life. She had severe paradoxical low flow, low gate and aortic stenosis, but she also had a 50% stenosis of the left anterior descending. So we thought, yeah, of course, we should make it as easy as possible if this disease progresses and someone has to fix it in a couple of years down the road. So we, again, decided to go for a commercial alignment, and I simply wanted to show this case to show how you can do it in a Portico or Navitor platform. So let me go ahead. My clicker lost connection. Okay, so now I can go on. So what has been proposed as a very easy way to do commercial alignment in Navitor or Portico cases is shown here. It's a paper from Lars Sondergaard's group, and you basically try to put the post and cusp overlap view on the right side of your screen, and by doing so, you basically put it right to the commissure between the left and the right coronary cusp. So, and as I said, we did it also in this case. So you see, we started in cusp overlap. And again, it was an easy deployment without rapid pacing, a patient with a tachycardic due to atrial fibrillation. And we also did a little zoom here for you, so you can see that indeed the post indicating the position of the valve was indeed on the right side of the screen, meaning it was basically exactly between the ostia of the right and the left coronary, and basically in the commissure. So released the valve in this position after a short check of its position in the left in the LAO projection, and this, of course, is the final angio showing a good valve function. But it also, if you stop, also shows nicely the position of the leaflets of the Portico valve, which again are intra-annular, and you can also, of course, appreciate the large cell design. And this, in addition with the commercial alignment, I think will make it very easy to treat the LAD if it becomes relevant for this patient in the future. So just to leave you with a discharge echo with no PVL and a mean gradient, of course, of 6. So as expected, a very good valve function.
Great, a nice case, very nicely to demonstrate this, Henrik. So would it be fair to say that with this type of intra-annular valve design, commercial alignment is possible? I think you just showed that, what the fluoroscopic markers look like, but it's not always necessary depending on anatomy and also depending on the fact that this is an intra-annular valve type. Is that something we could summarize it as such?
Exactly. This is currently our approach. We don't attempt it on all patients, but of course we use this valved system more and more in younger patients who also have coronary artery disease. So in these cases, we try to commercially align also this type of valve, even though it can be a little bit tricky because the posts are not as well visible as the head marker of the evolute, but in many patients you can do it. And as you see, it's not much of a trick to align this valve.
Okay, Flavio, so I think many manufacturers are now realizing that commercial alignment is something for the future as we move into younger patients who might, require coronary intervention, who might require valvular intervention. And I think we've learned so far that for both indications, commercial alignment is something that's desirable. How important would you personally find specific markers that would, make commercial alignment easier?
Well, it is important, especially when the patient has some degree of coronary artery disease. For normal coronaries, I mean, when you treat a patient above the age of 75 with normal coronary arteries, probably there is absolutely, the likelihood of getting into these coronaries is so low. But the fact that we are treating more patients, younger patients, and we have seen, 50% of them have some kind of coronary artery disease. It's absolutely important.
Okay, so just as a side note, I'm reminded a little bit of the very early TAVR days. There were actually, it's not a new idea, to put dedicated markers on TAVR valve stents. The Medtronic at some point had a valve called Engager in their portfolio, which actually had exactly that. That's just on a side note. We have another question from the chat, and I think we do have a minute to answer this, from Jorge Eduardo Chavariaga Quinceno. Please excuse my bad pronunciation. So he's asking, should each case be individualized according to anatomy found in the images to decide which device to implant? Henrik, what would your answer be?
Absolutely. I mean, this is, I think, our responsibility to choose the best valve for this very patient, basically regarding anatomy, outcome, future treatments. So I think absolutely, and I think we currently use something like 5 valve types in our centers. Of course, you have to have a large volume to be experienced enough in all of these valve types to know their weaknesses. If you have a smaller center, maybe you should go for maybe 2 or 3 valve types to be proficient in all of those. But I think you definitely need a selection, and you have to tailor your decision making for the anatomy and for the specifics of the patient.
Okay, so Flavio, just to sort of summarize for our audience once again, is it fair to say that today it's not only about safety and efficacy of the index procedure, but also, to think ahead and to prepare the way for whatever's needed in the future in that particular patient? And I think that's the question is aiming at from the chat also a little bit.
Absolutely agree. Although have in mind that in the US, 90% of the valves are only one type. In Europe, we have this different vision of using 4 or 5 different type of valves. Of course, very high volumes can have experience with different models, but most centers are dedicated to one valve. So it's a little bit of a change in mind. I think, as I said before, you have normal coronaries at the age of 70s. It doesn't matter which kind of valve you implant. You must be, let's say, confident with. Then with patients with coronary artery disease, then it becomes important.
Okay, great. Thank you. I think we have to move on. We have one last case that we wanted to show you. I'm going to show it from our experience. The topic here is, again, of course, coronary accessibility, and maybe in this case more than in others, it's preservation of coronary competence or patency. This was an elderly lady, 84 years, severely symptomatic, who had received a TAVI already. This was an intraannular SAPIEN 3. And this one had deteriorated and had developed a repeat severe stenosis with the given values here. And I think if you run the right picture, you can see by the coronary angio at baseline already that there is, for one, a tight distance from the valve or spatial relationship from the valve stent to the coronary ostia. And these are some images from the planning CT. So, of course, we confirm the landing zone diameters on the upper left-hand panel, but more importantly, maybe are the images to the right. For one, we can see that just by the values, the distance of the coronary takeoff seems comfortable, right, with 14 and 16 millimeters approximately. But what you can also see is that there is severe sequestration of sinus, so that the complete aortic root has become a tubular structure. And in the hockey puck view on the bottom right, one might even have the suspicion that this 26 valve is not completely expanded. So there must have been some really heavy oversizing that the implanters back then chose. So typically, I think for most of us, valve-in-valve procedures are done with supraannular valve designs. But here in this particular case, we were quite hesitant because of those close spatial relationships. So let me pause quite quickly here and ask the two of you, Henrik and Flavio, what do you think? Would a supraannular valve have worked in this particular case, or would you be a little hesitant regarding coronary occlusion?
Well, if I might go first, it's a trade-off. I mean, the potential advantages of a supraannular valve will be the lower residual gradient. But of course, the access to these coronaries will be painful. And in a case like that, of course, you need to think on planning your procedure with the project of coronary protection. I leave the comment on the intra-annular valve to Henrik.
Yeah, usually when we do valve-in-valve procedures, we also prefer supraannular designs. But I think in this case, it's probably not much of a benefit. If you have a tubular anatomy, I mean, there's no chance that the supraannular design has more space to expand compared to, you know, after treating a Hancock or somewhere where you push out or you have some valve remodeling by a balloon valvuloplasty after implantation. I think there's not much space on the supraannular position compared to the interannular position. So I think this probably doesn't give you a benefit to use a supraannular design in this kind of anatomy. So then, of course, you have to more think about what's the best for the coronaries. And I think keeping the neoannulars as low as possible might be helpful to re-engage the coronaries in this kind of anatomy. So I think I would also go for an intraannular self-expanding valve in this situation.
Yeah, these are exactly the thoughts we were having. So first decision was easy, like following your rationales, Flavio and Henrik, that supraannular wouldn't really trade off in a beneficial way or might even be harmful. So when then left with the decision for an intraannular valve design, we decided for self-expandable because of the repositionability. Of course, a sapien technically would be insertable here, but on the other hand, you know, just to add maybe to the potential safety of the procedure, we went for a self-expandable. And you can show the initial, you can see the initial positioning here on the left. For those of you who are not as familiar with the Navitor platform, there's a focal positioning marker towards the future inflow of the design of the valve, which should sit around the annulus. We intentionally implanted this valve a little lower because even in the crimped state, you can see that the commissural fixation of the leaflets of the Navitor are now above the sapien stent outflow. So if you could play the right video, all I wanted to illustrate with this is that we had an intentional lower implant and stopped, as we typically do with Navitor, after the first deployment step for an angiography. And following that, we let the valve go. You can see that it is still severely constrained within the sapien. And of course, we wouldn't leave it as it is, and post-dilated this mildly and expanded it inside the sapien. Next slide, please. And this is the final valve position with, of course, it's patent and a no leak, which typically is the case with valve-in-valves. And then we semi-selectively intubated, not intubated, but semi-selectively showed the coronaries. This is the left one. I think you can also see that the commissure is pretty much aligned with the sapien outflow stent, so that the leaflets are not above the coronary ostia. And just to complete this case, next slide, with a few echo images, there was no PVL. And the gradient was 3, which, you know, for an intraannular valve design, I think is more than satisfactory. Okay, so we're done with this case, and we have just a few more minutes to discuss maybe this one or the overall. I see that there is one comment from the chat, which I can read out. Robertas Pranevicius says, a useful tip which we use is to put in the last TAVI projection into the protocol so that the operator, which will get the patient at night, would know where to start. Not a bad suggestion. Huh? This would be a kind of a practical suggestion. I like it.
Definitely.
Okay. So we have a few minutes. We've talked a lot about commissural alignment and coronary accessibility. We might take a minute or two to talk about hemodynamics. We've hinted at it already because the general assumption is that supraannular valves perform superior to intraannular ones with regard to gradient. Henrik or Flavio, whichever wants to go first. Do you think that's necessarily true in all cases, or are there maybe subsets of patients where that old paradigm is not so true anymore?
Who wants to start? Flavio?
Well, each patient is different. As I said, there are patients with normal coronary arteries. There is no clear indication on how to deal with the lesions we find incidentally at the time of the TAVI preparation. But of course, we want to keep the coronary access free for patients living longer after the TAVI procedures. So I think we have to make the most of our efforts to do a good implantation, and the industry has to improve their technology to facilitate this task. Because of course, TAVI is getting a more and more widespread procedure. It's not only dedicated to some centers, and we have to think about the long-lasting follow-up of these patients. So it's an important issue. The concept of using different type of valves in different situations is always something that have to do with the renal function, the LV function, the amount of calcium, the diameters of the aortic root. I mean, it's not an easy situation in many cases. But we have to keep this in mind, which in the beginning, when we started 10 or 15 years ago, was not considered as important as it is now. I think that initiatives like this one, sharing our experience and trying to give the opportunity to other colleagues to think about this is the way to go.
Very good, Flavio. We have just 2 more minutes. Henrik, can I ask you to comment on the small annular subpopulation? So typically, we're somehow faced with the decision, use the perfect primary implant, which might be supraannular with regard to gradient, or preserve the perfect landing zone, which means use an intraannular valve maybe, and by that sacrifice the initial hemodynamic, benefit. What's your comment on this nowadays with the different valve types we've come to learn about?
Yeah, this is an important aspect that we haven't mentioned so far at all. And this is, of course, hemodynamics, because when we talk about structural valve deterioration, I think we always have to consider the starting point where the patient start out of with regards of hemodynamics and the initial gradient. And I think we have to aim for single-digit gradients after implantation to make sure that if they lose due to deterioration 1 millimeter of mercury over time, they start out with 8 millimeters of mercury, because I think this is what we've seen in the NOTION trial, where to everybody's surprise, the SAVOR, so the surgically implanted bioprosthesis turned out to be worse regarding structural valve deterioration compared to the early TAVI generations. And this was mainly due to, I think, because they started out with higher gradients, because the surgeons in this time caused more patient prosthesis mismatches than the TAVI prosthesis. I think this has changed. The surgeons have, I think, put a lot of effort into avoiding PPM nowadays. But in the early days, this, I think, was an issue. And this taught me to also not only consider, of course, PVL, pacemaker rate, and the coronary accessibility in these patients and younger patients, but also to have a very low gradient. So especially in small annuli, this is really can be a problem if you use a balloon expandable valve. So this is exactly what we do right now. We go for commercial alignment with an intraannular design for redo TAVI and also for the possibility to have easy coronary access, but we go for self-expanding and mainly the innervator in these patients, because we want to have a very low gradient. And in my experience, we achieve single-digit gradients in these patients, regardless if we use an Evolute or an intraannular self-expanding design, such as the Navitor or the Portico. So you can have the best of both worlds in small annuli.
Very good. So I'll just wrap up quickly in the last minute. So I think I want to thank both of you for a very, rich experience that you shared with us. I think we've learned a lot about the concept of coronary alignment. You've demonstrated different THV types and their, the consequences of implanting them with regard to that aspects. We've seen great examples of different anatomies. And I think in the very end, we could show that Navitor is maybe one new way of preserving coronary access by the stent design with the large stent cells, and also by its intraannular seating without sacrificing hemodynamics, as maybe the TAV and TAV cases demonstrated with a small landing zone. So I'd like to thank both of you once again for the lively discussion, the great examples, and you out there in watching for your attention, and I hope to see you sometime again soon. Take care and goodbye.